much, Laura, for the kind introduction. Okay, so how are you, everyone? Okay, I hope everyone is still fresh, even though it's going to be lunch soon. Yeah, and it's quite challenging actually giving talk at this hour actually. Okay, without further delay, I'll be starting my presentation. Okay, so I'm going to talk on schizophrenia and psychotic disorder. Okay, so it's a bit heavy also. Okay. How do we just... Okay. Okay, so these are the thing that I'm going to cover, so that by the end of the lecture, the talk, that you'll be understanding about the concept of psychosis, what are the causes, and schizophrenia itself, the features, and what are the best intervention for the care of schizophrenia and psychotic disorders. Okay, so what is psychosis? Okay, psychosis is not a symptoms. It's not a diagnosis. It's a symptom actually. Okay, some people may confuse saying that psychosis is an illness, is a diagnosis. Okay, so what is it actually? People were saying psychosis is a break of reality. Okay, so there is a loss of contact with reality. So people with psychosis, what do they experience? Yeah? They actually have difficulty to differentiate the what is real and what is not. Okay, and these disruptions are often experienced as seeing things, yeah, hearing things, believing things that aren't real, or having strange and persistent thoughts, behaviors and emotions. So most people say psychosis is frightening and confusing. Okay, and during the period of psychosis, there are disturbances in emotion, thinking and behaviors. Yeah, and the psychosis disrupts person's life. Yeah, the relationship, work, okay, and other usual activities and self-care can be difficult, yeah, to initiate and maintain. Okay, so yeah, so it affects the perception, cognition, behaviors and emotion. Yeah. Okay, so what are the symptoms of the psychosis? Okay, so the most common one is hallucination and delusions. Okay, so delusion is fixed false belief. Okay, this is a textbook's definition. Okay, so what does it mean is that they still have the strong belief about things that they really believe in. Okay, despite contrary. Okay, and it's very difficult, and it's irrational. Okay, examples of delusions are there are few concepts. Theme in the delusions itself. Okay, such as persecutory delusions. Okay, whereby they believe that there are people who are against them. Okay, spying on them, wanted to do harm things to them. Okay, that's delusion of persecution. Delusions of control, whereby people believe that something is controlling them. Okay, it's an external force. Yeah, that controlling their emotion, their behavior, their actions, their mind. Yeah, and then there is also delusions of reference. Okay, that something is related to them. Okay, delusions of grandiose, that they are very rich. They believe they are the most beautiful person in the world. Delusions of love, they believe people who are high people, VIPs, are in love with them, and so on. Okay, so those are the common delusions. Okay, what about hallucinations? Hallucinations is using the senses. Okay, so there is what you call auditory hallucinations, visual hallucinations, tactile, olfactory, and gustatory. Okay, so auditory hallucination, they hear things that is not there. Okay, and then they also seeing things. Okay, visual hallucination, they're seeing things that is not it's not there, but they see things. So it's different from the real perception, whereby I believe some of you may wake up in the middle of the night, okay, and then seeing things look like something is there in the toilet or in the kitchen, so but it's misinterpretation actually of the real things that is there. Okay, maybe a chair is there, but we see it as someone is there. Okay, tactile hallucination. Okay, they felt something is touching them. Okay, this is quite common also, especially for those taking substances. Yeah, they can feel a bug running through the underneath skin. Yeah. Okay, olfactory is they can smell things. Okay, smell things that is not there. Okay, only he or she can smell the things. Okay, gustatory hallucination. Okay, they can taste things that is not there actually, or they can taste things that is they felt it's a different kind of taste. Okay, so eating something and then felt it's tastes like stool, feces, for example. Okay, and then there is this disorganized speech. Okay, whereby we cannot talk to them, we can't understand what they are saying. It's incoherent and irrational. Okay, so and also disorganized and catatonic behavior. Okay, whereby they can have repetitive and senseless movement. Okay, in catatonia, they can have movement. They can, they can, if we lift up their hands like that, and it will stay put like that for long durations. Okay, so so these are the common psychotic symptoms. Okay. Okay, apart from that, also they also have these symptoms and cognitive difficulties. Okay, they have thinking difficulties. Okay, they are unable to concentrate. They have difficulties in concentration, memory, and ability to plan. And these make it more difficult for the person to reason, communicate, and complete the daily task. Okay, and in negative symptoms, okay, can have more of negative means they have loss of drive, a motivation. They don't have motivation or lack of motivation even for their own self-care. And this is not laziness. A lot of people say that mental patient is lazy. Okay, but it's not lazy, but it's due to the negative symptoms that they have actually. Okay, and blunted emotion or inappropriate emotions, whereby they have no feeling. Okay, they don't react to the things around them, or reacts or that reacts actually inappropriately. Okay, so when we talk to them, it's something that is funny, their face is just blunted, just no expression at all. Okay, and lack of eye contact, and sometimes they also reacting with anger and laughter when they are not appropriate. Okay, and also social withdrawal. Okay, so they are withdrawn from the community with the other family members, with the close friends. Okay, yeah. So and cognitive difficulties, they have problems in memory, okay, attention, and also executive function. So another way to look at it is they are experiencing of something that is odd, that is not usual. Okay, the thinking is weird. Yeah, it's out of the normal thing. It's impossible things to happen. Okay, and when they have this hallucination and delusion, disbelief, they react to it. So they behave according to the voices. They hallucinating, okay? Having self-talking. So we can see them talking to themselves, smiling inappropriately, laughing inappropriately. Okay, and also they sometimes react to the delusions. Okay, I have quite few cases, stories that can share. One of it is that, I have a 31 years old male gentleman. Okay, he actually has been coming to the hospital because of he believed that at home there is someone who has putting chips in the house, cameras, okay, and the chips in the head. So luckily he wants to come to the hospital. So he believed in it. So he react to it. So he closed the door, he closed the window, shutting down everything, and even go up to the to the roof to check where is the camera. Okay, so they can have this kind of behavior because of reacting to the symptoms. Yeah. Okay. I want you to see this. Okay. They can hear this. Okay, so what do you what do you observe from the video just now? Anybody, you can put in the chat box. So you can see from the video, okay, you can see a person who has auditory hallucination, okay, hearing things, okay. You can see their sensory is more sensitive, so they can hear things louder. Okay, so you can see from the beginning of the video, okay, you know, when they walk, then you can hear the steps, the footsteps, when they open the door, the glasses, so it is very loud. And towards the end, you can see the voices, people talking to her, to him. Okay. Disorientating. Okay. Yeah. So these are some stimulation. The video was a stimulation of hallucination lah. Okay. So in mental illness, we are using this what they call diagnostic and statistical manual of mental disorders to diagnose person having mental illness. Okay, so now it is a DSM-4. Okay, and another one that we also use is ICD-10. Okay, so so when we diagnose, okay, it has to have a number, a collection of symptoms. Okay, it cannot be only one symptoms. Okay, and then we diagnose, because I think nowadays a lot of people saying that, oh, I'm having this, I'm having depression, I'm having OCD, but people need to understand that it is a collective of symptoms rather than only one alone. Okay, and usually we will diagnose after we had done a thorough history taking. Okay, so we get history not only from the patient, okay, but also collaborative history from the family members, from the relatives and friends who are staying together and working together. Okay, and of course with the physical examination, and also then proceed with the appropriate investigations. Yeah, and in diagnosing, before we diagnose psychiatric illnesses, okay, we have to rule out organic causes. Okay, so the medical illnesses, okay, we have to rule out. So in diagnosing a person, okay, so apart from the symptoms, it has to be to fulfill the duration, the time, okay, and another component is it must have impaction, okay, on the function itself. So you can see the severity, okay, and this is how we diagnose. Okay, and for person with psychosis, there are a lot of differential diagnoses. Okay, the thing that the commonest one is schizophrenia. This is the cause of from the psychiatric illnesses. Okay, so and each has different criteria. Okay, so before diagnosing person to have schizophrenia, it has to have the collection of the symptoms, okay, and also the duration, which is 6 months prodrome. Okay, and but for brief psychotic disorder, it's only 1 day to a month. Okay, so and they have the psychotic symptoms as well. Okay, so yeah, so what are the causes of psychosis? Okay, the cause of psychosis can be different for everyone, and the research into it is happening all the time now. Okay, and psychosis can be triggered with by a number of things. Okay, one is the medical illnesses. Okay, so medical illnesses, things like epilepsy, okay, infections, either brain infections, or even other types of infections, head injury, mercury poisoning, okay, Parkinson's disease, Alzheimer's disease, okay. So they can have experiencing the hallucinations and delusions, okay. Apart from that, substances, cannabis, okay, LSD, okay, and also alcohol, yeah, and then stresses. Okay, they can have severe stresses in the past that can lead to the psychosis later on. Okay, so experiencing abuse or traumatic event in the past, okay, can also trigger their psychosis. Okay, and part of specific mental illnesses lah. Okay, so things like schizophrenia, major depressive disorder that is severe, will present with psychosis. Okay, bipolar, yeah, substance-induced psychosis, and so on. Okay, so these are the medical and psychiatric causes of psychosis. Okay, so as simple as delirium. Okay, people with delirium, okay, due to a lot of causes, okay, they can present with hallucinations, okay, usually is visual hallucinations, okay, or even delusions, yeah. So as simple as hyperglycemia, yeah, hypoxia, ICU psychosis is quite common also, okay, and then medications interactions or withdrawal, okay. Medications also can cause, okay, a common one is steroids, yeah, sepsis, electrolyte imbalances, yeah, sleep deprivation, okay, and other medical causes, so autoimmune. So we have to those are the list, okay. So we have to rule out those causes first before we say this is a pure psychiatric illnesses, okay. So I've mentioned about some of the psychiatric causes just now, the bipolar, severe depression, okay, brief psychotic disorder, okay, schizoaffective and schizophrenia. Okay, so there are these are the causes of the mental illness. Okay, I'm going to be a bit fast here. This is I've mentioned just now. Another one that I forgot to mention is delusional disorder. Okay, delusional disorder is they present with a lot of delusions. Okay, but they can have also hallucination, but the functions is maintained. So we can, I think we have quite a number also patients who are having a delusional disorder. Okay, schizoaffective is whereby a person having psychotic symptoms and also mood symptoms together, and there be a period of 2 weeks whereby they only have psychotic symptoms without the mood symptoms. Yeah, so yeah, okay, so these are the thing that falls under term of psychosis. I've mentioned most of it. Okay, yeah. Okay, so you can see here, okay, if there is a person coming to us with psychosis, we need to rule out the medical causes, okay, and before saying this is a primary psychiatric illnesses. Okay, so yeah. Okay, and psychosis, again, I want to highlight psychosis is not a pathognomonic of psychiatric illnesses. So it can happen in organic causes, in medical illnesses, yeah. So these are the DSM-5. So there's a schizophrenia spectrum, okay. So from schizotypal personality disorder, okay, delusional disorder, brief psychotic disorder, schizophreniform. Schizophreniform is before we say that a person is having schizophrenia because of the duration. Okay, so it's between 1 month to 6 months. Okay, schizophrenia more than 6 months, schizoaffective, and so on. Okay. Okay, so again I mentioned the symptoms. So then we see which one is predominant. Okay, so if it's only a psychosis and also delusion, which is hallucination and delusion. Okay, so then we see whether if only delusion predominantly, it will be delusional disorder. Okay, and if it's both, then we see the duration. So if less than 1 month is brief psychotic disorder, between 1 to 6 months is schizophreniform, more than 6 months is schizophrenia. Okay, and those with mood symptoms, okay, then we can say is schizoaffective, or which one is more dominant, okay, depression only, then it's a severe depression, or any symptoms of mania, then we can say that is bipolar. Okay, so this is the spectrum of schizophrenia. Okay. Okay, I don't think I will go on to talk about each of these. This one just that I want to highlight schizophrenia. I'm going to talk more of schizophrenia itself. Okay, but again I want to mention the most of the thing is depends on the duration, the severity, and the symptoms itself. Okay, so schizophreniform is between 1 month to 6 months. Yeah, bipolar, there is mood symptoms there, especially the mania symptoms. Schizoaffective, okay, so having both mood and psychotic symptoms. Okay, and depression with psychosis is those with depressive symptoms predominantly, and having at the same time psychotic symptoms. Okay, so I wonder whether you have ever seen this movie, Beautiful Mind. Okay, so in this movie you can see a lot of psychotic symptoms played by Russell Crowe. Yeah, so schizophrenia is actually one of the common mental illness. Okay, it is not a split personality. Okay, and schizophrenia illness, okay, causes major disturbances to the brain circuit, okay, whereby the thought process becomes miscircuited, okay, disconnected, so then it affects the person's thought, content, and logic, and makes the person's thoughts incoherently. Okay, so they have disconnected speech that is not making sense. Okay, and as everything seems to be jumbled up. Okay, and also sometimes they behave in unusual manners because of the symptoms just now. Okay, so they lost touch to the reality. Yeah. Okay, a little bit on schizophrenia. Okay, so the median incident rate is 15.2 per 100,000. Okay, and it's common. The incidence is higher in male, urban, and migrant population. Yeah, lifetime prevalence is 1%. Okay, and the incidence is about 15 to 30 new cases per 100,000 population per year. And male and female is same risk. Yeah, and usually onset of male is earlier compared to female. Okay, so male usually presents in adolescent age, 15 to 25 years, compared to female at 25 to 35 years. Okay, and onset before at the age of 10 and 60 is extremely rare actually. So we have to rule out organic causes first before saying this is a schizophrenia. Okay. So you can see here, females tend to present later age. Okay, the yellow one. Okay, and the green is the male. So you can see they present at earlier age. Okay, another features of schizophrenia is 80% are single. Okay, are divorced, widowed, or separated, and 70% are unemployed. Okay, and they seems to have issues on overweight. Okay, 14%. 16% is actually most of them are having a normal BMI, and 4% are obese. Okay, interestingly, the duration of untreated psychosis, okay, meaning to say duration where they are having the symptoms of psychosis before they come to get treatment. Okay, so for Malaysia, the mean duration of untreated psychosis is 28.7 months, which is almost 2.5 years. Okay, and male has shorter duration compared to female. So why is this? Okay, I think we believe this is because of more of the one is the stigma and the cultural belief. Okay, so that leads to the delay in the in bringing the patient for assessment. Okay, and also the stigma itself in the community. Okay, family history and comorbid conditions, 21.6% having positive family history, 20% had some form of comorbidity. Okay, and about 80% okay having substance abuse, cannabis and amphetamines, and 40% have comorbid medical illnesses, especially hypertension and diabetes. Okay, this is probably because of the metabolic syndrome that they had, probably secondary to the side effects of the antipsychotic. Okay, more than half are treated as outpatient, and half of the patients had their first contact as inpatient. So datang-datang terus admit to the hospital. Okay, and comorbid with the substances. Okay, individuals with mental illness can also have higher risk for substance use issue. Okay, and also the comorbid. Okay. Okay, what are the symptoms in schizophrenia? Okay, so of course the psychotic symptoms that I've mentioned. So hallucination, delusion, okay, catatonia, and also the negative symptoms. So they have positive, negative. They have 4 domains. Okay, I'll be talking about that later. Okay, so in schizophrenia also it affects the thoughts. Okay, so they have difficulties in concentration or attention. Yeah, they have the odd ideas. They have difficulties in memory and planning. Okay, so they have more difficult for the person to reason out things, communicate and complete the daily task. Yeah. Okay, so in schizophrenia they have these positive, negative symptoms. Okay, positive symptoms is the things that we see. The symptoms that we can see, such as hallucination, delusion, disorganized thoughts, speech, and the bizarre behavior. Okay, negative symptoms is things that you can also see. Okay, but sometimes it's not really prominent. Okay, so things like flattening effect. Okay, so no emotion. Okay, so you talk to them like what I mentioned earlier. Talk to them, they don't have emotion. Cannot see the emotion in the face, the facial expression. Okay, reduced social interaction. They are withdrawn. Okay, anhedonia, lack of enjoyment in things that they used to enjoy before. Evolution. Okay, no motivation to do things. Okay, alogia, reduce in speaking, catatonia, and moving less. Yeah? There is also effect on the behavior and emotion, so they react because of what they believe, because of the hallucination and delusion. They react, so they behave. They react on it. Okay, so changes in the behavior includes also the sleep disturbances, social withdrawal, social isolation. Okay, and also reduce in ability to carry out the work and the social roles. Yeah. Okay. And emotion, they can have anxiety. In psychotic symptoms, quite common also they have anxiety and depressive symptoms concurrently. So also irritability is quite common also. Suspiciousness, okay, blunted, flat, inappropriate emotion that I've mentioned earlier. Change in appetite, okay, reduced energy and motivation. So this is more towards the negative symptoms. Okay, so these are the 4 domains in schizophrenia. Okay, so they have these positive symptoms that I've mentioned: hallucination, delusion, disorganization, catatonia. Then the negative symptoms, okay, the 4 A's, we call it as 4 A's: affective flattening, no expression, anhedonia, alogia, avolition, and social withdrawal. Apart from that, also it affects the cognition. Okay, so affect the attention, memory, executive function. Okay, mood symptoms, yeah, so depression, hopelessness, suicidality, anxiety, agitation, and hostility. Okay, so these are the 4 domains. So it all affects the social and occupational function. Okay, so it not only the work but also the the socially. Okay, so the relationship with others. Okay, and also the self-care. Okay, so yeah, and they have lack of insight also. Okay, and issues when they have issues with comorbid substance abuse. Okay, so these are the 4 domains that I've mentioned earlier. Okay, and each of the domains actually involved in the brain circuit, malfunctioning of the brain circuit. Okay, so positive involved in the mesolimbic. Okay, negative mesocortical and prefrontal cortex, nucleus accumbens, reward circuits. Okay, so it affects that. Okay, cognitive, so the prefrontal and also lateral cortex. Okay, aggressive symptoms involve the amygdala, orbifrontal cortex. Okay, and also affective, the ventromedial prefrontal cortex. So actually, biologically there is biological causes of it. Okay, so the DSM-5, these are the criteria. Okay, just to I want to highlight that must have at least 2 or more of the symptoms. Okay, from hallucination, delusion, disorganized speech, disorganized behavior, and negative symptoms. Okay, so the duration is 6 months, and there is a significant deterioration in the function. Okay, and it's not because of other medical illness. Okay, there is this term we call as early psychosis. Okay, these are the some of the signs and symptoms that strongly indicate that a person has actually having episode of psychosis in the past. Okay, so one is deterioration in the job. Okay, so worried about the drop in the grades. Okay, trouble in thinking clearly or concentration. Okay, and there is a drop in the self-care, personal hygiene, and can see the changes. One of it is also become withdrawn. Okay, spending more time alone than usual. Okay, and then inappropriate emotion or no feeling at all. Okay, and of course the one that is more prominent is like the delusion. So they have persistent unusual belief. Okay, and also the hallucination, hearing things, seeing things. Okay, so but the one that usually that we miss, I mean people always miss, is the above one. Deterioration in the grades, job performance, clear trouble thinking. So these are the things that is actually quite common, but we always miss it. Okay, so and in a course of schizophrenia, okay, we have this what we call as prodromal phase. Okay, so those are the things that I mentioned earlier is part of the prodromal phase. So it's actually can present from childhood or adolescent, and it may precede the psychosis, onset of the psychosis by months or years. So schizophrenia typically starts in the late adolescent years, okay, and the illness starts insidiously, okay, which may be confused with adolescent changes during this period, like the adolescent being moody, irritable, more secretive, and like to keep more to themselves. Okay, so we tend to confuse with this. Okay, and changes during the prodromal period are non-specific, so it can be mistaken as having depression or anxiety problems, and hence it is often diagnosed only years later during the early adulthood. Okay, so this is between 10 to 20 years. Okay, so this is between 20 to 40 years, and usually it's more stable in the after 40 years of age. Yeah. Okay. Okay, so we have this three stage. Okay, so prodromal, the active phase, which is the psychotic phase, and also stable phase. So it varies, the degrees varies and leads to recovery. So it is important to intervene early. So early treatment is actually very, very important. Okay, so that can have a better prognosis. Okay, so prodromal symptoms as I mentioned, varies from person to person. Okay, and it can be last for months to years. So as I mentioned, social withdrawal, difficulty in concentration, difficulties of thinking. So it can affect the studies. Okay, especially for the teenagers. So you can see deterioration in the school performance, sleep disturbances, odd belief. And then physical, so as mentioned, sleep disturbances, withdrawal from the family members. Okay, and then the second phase is the acute phase. Okay, so this is the active phase whereby they can have all the positive symptoms lah. So hallucination, delusion, disorganized speech, bizarre behavior. Okay, crisis. So then we have the recovery phase. So usually recovery phase is affected by the treatment that been given. Okay, so if the treatment is of course biopsychosocial, okay, and that's why it is important to intervene early. Okay, so the recovery process will vary in duration and degree of functional improvement. So different patients have different recovery process. So who gets a schizophrenia? Okay, so it can be anyone. Okay, anyone. So it's common in men and women. Okay, and without mengira latar belakang bangsa, so everyone can. Okay, usually starts between the age of 16 to 30 years old. Okay, so again, men earlier presentation compared to women. Okay, and what causes schizophrenia? Okay, so it's believed it's due to combination of factors including genetics, biochemistry, and stress. And biological factors could be genetics, okay, vulnerability, okay, changes in the brain or dysfunction in the neurotransmitters in the brain, okay, and stress or drug use can also trigger the psychotic symptoms in vulnerable people. Okay. Traumatic events such as death, war, sexual or physical assault or abuse before can also trigger psychotic episodes. So okay, for risk factors of schizophrenia, for family history, strong family history is actually indicates that there is risk in the person to have a schizophrenia also. Okay, so it's about 10 to 15%. Okay, although the risk is higher, it is important to note that 85 to 90% will not develop schizophrenia actually. Okay, and then risk factors of obstetric complications. Okay, this has been done. Studies have been done to show the association between these. Okay, so history of complicated obstetric history. Okay, so preeclampsia, extreme prematurity, and hypoxia during childhood. That's why in the history, when we take during pregnancy, antenatally, how was the patient? Okay, so we want to know that also in the history. So we will relate it to this the past obstetric history. Okay, cannabis users, abusers. Okay, individual living in higher level of urbanization. Okay, offsprings of older fathers, unmarried mother, and those history of childhood central nervous system infection. Okay, so these are the risk factors. Okay, so again, first degree biological relatives of persons with schizophrenia have 10 times risk, okay, of developing the disease compared to the general population. So the causes, I've mentioned all these things earlier, but just want to highlight the neurobiology. Okay, so the dopamine. Okay, we have the dopamine hypothesis. Okay, so hyperactivity of dopamine in the mesolimbic mesocortical system. Okay, serotonin, excess serotonin cause both positive and negative symptoms. Okay, and other neurotransmitters such as norepinephrine and GABA also. So why is it important? Because it relates to the antipsychotic, the medication. Yeah, psychological theories and environmental theories also. High expressed emotion in a family is one of the ongoing stressor for a patient of schizophrenia. So living in an environment of high EE, okay, high expressed emotion, whereby the family is overprotective. Okay, overprotective also not good. So cannot do this, cannot do that. They protect the patient so much, okay, until cannot do anything. Okay, critical, overcritical. So commenting a lot of things, you know, giving bad remarks to them. Okay, hostility. Yeah. Okay, so living in that kind of environment is also will trigger the psychotic symptoms. Okay, so this is the dopamine pathway that I mentioned. Okay, so the 4 dopamine pathway. I think this one, if we are talking about the antipsychotic, it's good if we can relate to this. Okay, so mesolimbic, okay, that causes the positive symptoms. Yeah, mesocortical, okay, the negative and cognitive, and also the affective symptoms, negostratal symptoms. So this is whereby the EPS, you know, the side effects of the antipsychotic, and tubero hypophyseal pathway. Okay, tuberoinfundibular tract. Okay, so there is also diathesis, stress diathesis model. Okay, so usually this explain the disorder of behavior that is tract that is result of interaction, yeah, between genetic predisposition, vulnerability, and the stress. Okay, and usually caused by life events and factors. So in schizophrenia, a child may have inherited the genetic, the genes from the parents. Okay, this means they are predisposed to the genes. Okay, but however, environmental factors, nature, such as stressful life events, okay, may trigger the activation of the gene. So it can be dormant there, but if the environmental is okay, it will not trigger. Okay, so when the activation of the gene is activated, triggered, then can result in schizophrenic episode. Okay, so yeah. Okay, so in Malaysia setting, okay, we hear a lot of cases, a son strangled the mother, a son killed a wife and the children. So why is this happening? And when we investigate, when we take the history, we find out that actually they are reacting to the hallucination and delusions. Okay, so the treatment is not there. Okay, and of course another thing that is also contribute to it is the substance. Okay, so in Malaysia, the duration of untreated illness is quite long, 159 weeks. Okay, and most of the cases, they go to seek treatment in the traditional healers first, rather than seeing us doctors. Okay, so we have patients that come to us because of to fill up the OKU form. Okay, and he has been having psychotic symptoms for the past 20 years. Okay, so now he is already 40 plus. Okay, so has been kept at home for the past 20 years. Yeah, so they only come when either the patient become aggressive, okay, unmanageable, or like that is want to fill up the OKU form. Okay, so it is sad. Okay, when actually the treatment can be given earlier if they bring the patient to see us, to be assessed first, and then we intervene. Okay, so how do you want to reduce the duration of untreated illness? One is to improve the recognition. So that, I think this is what we are, Laura and the team is doing, increase the awareness. So once we know the awareness, we know what are the signs and symptoms, then we can educate. With that, we can educate the public on the early warning signs and so on, and then emphasize on the seeking treatment, seeking help. Yeah. Okay. You can see here early psychosis. Yeah. This is the prodrome period. Okay, so every time they have these episodes of psychosis, there is a progressive brain tissue loss. Okay, so you can see it's every time there will be brain tissue loss. So this will be ongoing, and this will leads to treatment resistance when the relapsing and the residual symptoms is chronic. Okay. And that's why we need to intervene early, because the treatment response is better in the first episode than when a patient having multiple episodes of psychosis. There is lower recovery rates and poorer degrees of recovery, and more time to respond if we start the treatment later. Okay, so that's why we need to intervene early. Okay, so you can see here this is a normal adolescent's brain. Okay, so those with schizophrenia, okay, they have loss of the tissue. Okay, the gray matters. Yeah, so 5 years later, you can see it's more of red. Red is already more than 10 to 15% loss. Okay, and this is a healthy brain. This is a schizophrenia patient's brain. Okay, so you can see cerebral atrophy, okay, decrease in the cortical gray matters, enlargement of the lateral ventricles, hippocampus is smaller. Okay, so yeah, so we need to in schizophrenia they have reduced life expectancy. Okay, so because they have high risk of suicide and accidents. Yeah, they have comorbidities, diabetes, cardiovascular, okay, cancer, lifestyle choices. They usually most of them actually they have unhealthy diet and no physical activity because of the nature of the illness. Also, they're not motivated to do anything, kan? So the physical activity is less. Okay, excessive smoking, okay, and abusing the alcohol. So and the medication, the antipsychotics relate to the metabolic syndrome. Yeah, and a physical illness diagnosed late usually and treated insufficiently. So there is a reduced life expectancy in schizophrenia. So we need to use the good prognosis, okay, in patients, so that we can treat them better. So those who has good prognosis is those who has sudden onset, shorter episode of untreated period. Okay, so when we know the good prognosis, what are the points for, then we should use this and relate it to our patients. Yeah, no psychiatric history in the past, prominent mood symptoms. Yeah, paranoid type is actually a good prognosis compared to the negative symptoms. Yeah, older age of onset. Okay, so older age of onset, they are married. Having good work record, good previous personality, good psychosocial adjustment, good social relationship, no family history of mental illness, of schizophrenia, and compliant to medication. Okay, so we can see in the poor prognosis thing is illicit substance. Okay, younger onset. So the other thing is opposite to this. Okay, so those this is almost the same thing that I've mentioned. Okay, so that's why we need to highlight shorter duration of untreated illness, psychosis. Okay, and also the substance, lack of insight is one of the poorer prognosis. So we need to intervene, improve the patient's prognosis. How? So one is by intervene early, ensure the adherence, okay, or the compliance, okay, and also the psychosocial rehabilitation. Okay, so that with that we can improve the prognosis, yeah, treatment adherence, and also school and work attendance and social supports. Okay, so with that also we can, when we intervene early, reduce the risk of hospitalization, the needs of hospitalization, family disruption, because we can see in chronic case of schizophrenia, the family disconnection of the family is an issue actually. Okay, suicide risk and symptoms relapse. Okay, so we want to reduce this. Okay, so what are the goals of care in schizophrenia? So mostly is, of course, one, we want to reduce the symptoms. Okay, reduce the symptoms, reduce the periods of hospitalization, risk of relapse. Okay, and improve the function. Okay, or preserve the function, so that we can then later on improve the quality of life. So the cognition, okay, improve the social networks, and also of course the employment. Okay, so these are the target. Okay, so ultimately we want to improve all of these: symptoms reduction, social skills, the function itself, and quality of life. Okay, yeah. So our ultimate goal is for recovery actually. Okay. This one I've mentioned. Okay, so studies have shown that when we have early intervention, okay, there'll be better clinical, social, and vocational outcomes, reduce inpatient stays, and they are better engaged. Okay, and reduce risk of second relapse actually. So the number to treat is 8. Okay. So in another study by Lieberman, you can see here the orange one, whereby the duration of illness is shorter, which is 10 weeks. Yeah, so compared to 2 years. Okay, so you can see that here there will be improvement of the prognosis itself. Okay. So benefit of early intervention, okay, reduce the morbidity, more rapid recovery, better prognosis, preservation of psychosocial skills, the support, the communications, decrease need of hospitalization, and of course cost effectiveness. Okay, so what are the early intervention that we are need to do is, one is in terms of the reduction of the symptoms is the pharmacotherapy. Okay, so it's biopsychosocial. Okay, and then we have the psychotherapy. Okay, includes the psychotherapy which I think Ivana will be talking about later on. So CBT, social skills, CBT, RCT. Okay, family therapy, care management, and also supported employment. This is more of vocational employment. Okay, so okay, for this, okay, we know already what are the poorer outcome just now. Okay, so these two, the longer of duration untreated psychosis and poor medication adherence, is actually modifiable compared to other things. Other things is not modified. Okay, so that's why it is important to encourage people to come and seek treatment earlier. Okay, and also the medication issues. So we need to psychoeducate patients on the issues of compliance or adherence. Okay, so like even earlier also got discussion on the adherence. Yeah, so a lot of factors. Okay, it's patients, even the clinical factors. Okay, the medications factors and the treatment factors. Okay, so there are a lot of reasons for poor medication adherence in schizophrenia. Okay, lack of insight, cognitive impairment, so they're not able to remember to take pills, not to able to plan ahead, so the executive functions is impaired. Negative symptoms. Okay, no initiative to take the pills, no motivation to take the pills. Okay, and another one is side effects of medications, and also the substance. Yeah. So so that's why psychoeducation, regular counselling on the treatment and adjustment of the medication if there is patients complaining of the side effects. Yeah. So I'm not going to touch on the medication as it's going to be touched later on. Yeah. Okay. So okay, the psychosocial intervention. Okay, so mainly is to assist in the recovery phase. Okay, so improve the individual's ability to handle stress, yeah, adherence of medication, illness self-management, understand about their own illness, better communication and coping skills, and of course the quality of life, and to promote the recovery, the integration into the community itself. Okay, so in psychoeducation we educate about the illness itself and how to best to manage it. Okay, so it helps in reducing the relapse. Yeah, so also we psychoeducate the family, so family intervention is also important here. Okay, social skills training, we teach them how to socially do things like, you know, communication skills, how to use money, how to integrate into the community. Supported employment is the one that employment, whereby we now going towards place and train rather than last time train and place, but now is place and train. So in Malaysia itself, we are working together with SOCSO or Pekeso. We have a restart clinic, we have restart program whereby they are helping us to give works, you know, job to opportunities to our clients. So we have CRT, CBT, and counselling. These are some of the psychosocial treatments for schizophrenia. The CBT, CRT, family therapist. So basically in family therapies, it also involves the psychoeducation, and how do we do the crisis intervention. We teach the family what do they do if there is a crisis, and help the family to support them and reduce the burden of care. Psychosocial rehabilitation, so this is the one that I mentioned: social skills, supported employment, environment, and family intervention. So these are the things also that we do: basic living skills, so that patients will be able to continue living in the society and have an optimum productive life. So money management, occupational training. These are the psychosocial rehabilitation also. Because we people with schizophrenia often have trouble finding or keeping a job. So because this is likely due to the disease itself that affects the thinking, concentration, and communication. So that's why we need to train them on that also. It's part of it. So this is evidence-based practice that we are incorporating it into our management. So one thing that I want to highlight is assertive community treatment. So this approach is managed by a team, which includes psychiatrists, nurses, psychologists, social worker, and even the pharmacists. I think tomorrow there will be one lecture on this also. And we also actually highlight on the shared decision making. So for those who are educated, we really have this shared decision making, and for those who are not, we usually have this discussion with the family members first, and also highlight on the peer support. So challenges in schizophrenia, these are the common one: stigma, substance, unemployment, lack of facilities, in terms of even medications itself, and the chronicity of the mental illness. So a lot of stigma, skiller, aggression, they cannot do normal things, they cannot work, it's lemah semangat, mengada-ngada. So these are the comments or things that people always say towards our patients. And violence is a very common myth in people with schizophrenia. Actually, a very small percentage only people experience psychosis may become violent, and people with mental illness, specifically those with psychotic illnesses, often portrayed in the media as possibly unpredictable, violent, and dangerous. So in the past, it could be due to not effective treatment for psychotic illness. Like last time, they only used chlorpromazine. So untreated people with schizophrenia may be likely develop aggressive behavior. Okay, and those with a substance, taking the substance. Okay. Okay. So these are some of the patients' comments that I compiled. Okay, I felt as though I was in Wonderland. None of my family members or friends understood me. Why? I had a calling from a voice in the sky. I was lost and lonely. The sense of shame and guilt I felt because I was incapable of functioning day to day as an adult left me isolated from others and aggressive to those who cared and wanted to help. Okay, so you can see how's they're feeling, yeah. And it is an illness that can be treated just like any other. I don't choose or want to be psychotic anymore than other people choose or want any other types of ill health. Okay, so it's just happen. It can happen to anyone. Yeah? The extremes of behaviors and emotion played havoc with my relationships and daily functioning, to the point where the simplest of tasks overwhelmed me. I think a routine of structure, quiet and unpressured environment combined with medication was ultimately the key to recovery. Okay, so they actually realized the importance of medication and also the psychosocial support, okay, that can give to recovery to them. So the point of recovery isn't to live without ups and downs. Actually, it's learning how to live with the ups and downs. Okay, so we can't be, totally let it go, but to live, how to adapt and adjust to it. Okay, so I like this the say for this. So how do we help people with psychosis or schizophrenia? Okay, so I usually like to use this these basic things lah. This is what we are using for PFA and also mental health psychosocial support. Look, listen and link. Okay, so we look, so that's why it's important that we understand and we have the knowledge and awareness on these mental health issues and problems and the signs and symptoms, the illnesses. Yeah, so with that we can observe. So we look our family members, our friends, our colleagues. Yeah, so then when we notice them having some changes, that's where we go and ask them. Okay, and because people with psychotic disorder will not often reach out for help actually. Okay, someone who is experiencing profound and frightening changes such as the psychotic symptoms will often try to keep them as a secret. Okay, so if you are concerned about someone, approach the person in caring and non-judgmental manner to discuss your concerns. Yeah, and then let them know that you are concerned and want to help them. Yeah, and the person you are trying to help might not trust you in the first place. Okay, and might be afraid of being perceived as different, and therefore they may not want to open to you. But we need to try to give support to them, give information, and encourage them to get appropriate help from the professional. Okay, so look, then we listen non-judgmentally, and then we link. Okay, so we link, so we get practical things is that we help them to do small practical bantuan practical. So we help them to bring them for follow up. They buy things for them. So like during the PKP kan, so these are the things we can do even in other situations lah. Okay, and when they are having the psychotic symptoms, okay, you don't deny, you don't be against what they say, okay, because they are ill, they strongly believe with whatever that they the delusion that they have, okay, or the auditory hallucination. So we can't go against that because they strongly believe of that. So what we do is we go into the stories, okay, and the only thing that can help in that is medication. So that's why they need to get medication as soon as possible. Okay. So what is our take-home messages? Is one is schizophrenia is a complicated illness, okay, but it is actually treatable, okay, but management of schizophrenia is challenging. So start treatment early, okay. In early intervention leads to good prognosis, yeah? And each relapse associated with brain tissue loss. So relapse causes multiple complications and declining in the function, recovery, and management involve biopsychosocial, okay, and psychosocial intervention is part of the management of schizophrenia actually, and treat a person with schizophrenia as like you would like to be treated. So there shouldn't be difference, yeah. So I think that's all for me, okay.